In this video, we are going to demonstrate how to resuscitate a newborn. First of all, preparedness is very important. We will go through what equipment is necessary to be prepared before the baby is born. At the same time, it is important that you go through the history and the maternal records to identify any risk factors for the baby. These risk factors could be prematurity, any abnormalities in the CTT, or risk factors for sepsis that is present in the mother. So it's extremely important that we are aware about these conditions. Next, meet the mother, introduce yourself, and talk to the mother that you are going to provide care for her baby. Next, we will go through what equipment we need to prepare for the delivery. Let's go through the equipment. First of all, you have to wash your hands and then wear 2 pairs of sterile gloves. And then we are going to check all the equipments to see whether they are functioning correctly. This is the self-inflating ambu bag. So this is where we connect the oxygen, and this is where we connect the mask to the baby. So this is how you are going to connect the mask, fix the mask into the ambu. You're going to hold the mask like this and then fix it very snugly. I will show you how to choose the correct size of mask later. This is where you connect the oxygen source. For a term baby, you can commence resuscitation without connecting to oxygen, but for a preterm baby, we use oxygen from the beginning. It's important that we check whether the ambu is working. So for that, what you do is you cover this end and then squeeze the ambu bag. And then what you need to observe is to see whether this valve would pop out. As you can see here, valve is popping out. We know this ambu is functioning. We will need different sizes of masks. As you can see here, there are a couple of sizes of masks that is available to be chosen for the baby. You will also need a laryngoscope. Newborn laryngoscopes have straight blades. Make sure there's a good light source. We need endotracheal tubes as well. So what is particular about newborn endotracheal tubes is that they are uncuffed. Generally, we use size 3 or 3.5 for a term baby. You will also need an airway, oral airway. I will show you later how to choose the correct size for a given baby. Be ready with the suction catheter and the suction apparatus, but we are not going to routinely suction all the babies. We will discuss the indications later. You need 2 warm towels and a hat to keep the baby in normothermic situation. Adrenaline is essential for resuscitation. This is available in 1 in 1000 strength. This has to be diluted into 1 in 10,000 solution. The dose from 1 in 10,000 solution is 0.2 ml per kg. And this can be given as long as the heart rate remains less than 60 beats per minute every 3 to 5 minutes. The other medications include calcium gluconate, sodium bicarbonate, 0.94% saline, dextrose, as well as naloxone. This is the warmer or the resuscitator. Make sure this is pre-warm. By the time the baby is being delivered, This walnut should be ready and warm enough to be able to keep the baby in a warm condition. Now we are ready to receive the baby. Remove your first pair of gloves and be ready with the second clean pair of gloves. When the baby is being delivered, assess the baby's situation. We use four parameters for this purpose: C, T, B, H. C for color, T for tone, B for breathing, H for heart rate. All the babies, when they are born, initially they are cyanosed, but a healthy baby will change the color first into centrally pink color, followed by peripheries also turning into pink color. This happens within a couple of minutes. But a baby born in poor condition will either continue to be cyanosed or in worst situation could appear pale. Second parameter is the tone. Healthy babies should appear with a good tone where the limbs are flexed and you can observe beautiful symmetrical movements of all four limbs. If the baby is born in floppy condition, we will be very unhappy about the baby's situation. Third thing is breathing. So if the airway is open and the baby can hold good breaths, babies will be crying, or they will be taking regular breaths effectively. If the newborn is taking irregular breaths, which are ineffective or apneic, this needs intervention. Final parameter is the heart rate. So we have to either listen to the heart using the stethoscope, or in the initial few minutes, you can palpate the umbilical cord for the cold pulsations. We don't have to count the number, we just listen to the rhythm. If you can hear a rhythm like there are bit more than 100, we will be happy about the heart rate. But if the rate is slow, this is close to 60. So we know the patient is having bradycardia. If you are not happy about the baby's condition, you will have to immediately cut the cord and take the baby to the resuscitator. But if the baby is born in good condition, please don't separate the baby from the mother. Leave the newborn on the mother's chest while making sure the baby is kept warm. You can wipe away the wetness and cover the baby with a warm towel. Put a hat on and then let the mother and baby to have some initial skin to skin care. If the baby is ready, baby can even go for the very first breastfeeding. Let's go through the steps in resuscitating a newborn if that baby needs help. So let's assume this term baby did not cry at birth and was born floppy, was cyanosed, and the heart rate is. So this baby needs support at birth. So we are going to take the baby under the warmer, keep the head in the neutral position, and then we are going to call for help. Next step is to wipe away the wetness of the baby. Wipe the head also. Put the warm hat on and then cover the baby with the second warm towel. In the real situation scenarios, you have to do this really quickly, but for demonstration purposes, I'll be demonstrating very slow. Let's see how to keep the head in the neutral position. So that means baby's ears are parallel to the surface and the eyes are looking at the ceiling. So the general natural tendency for the baby is to flex the neck like this to come into a flexed position, which is going to obstruct the airway. This is hyperextended. This should be avoided. This is your neutral position. So most of the babies, when we conduct the initial airway maneuvers, that is keeping the head in the neutral position, they actually recover. In this situation, you don't have to continue with the rest of the algorithm.
We need to take extra precautions to maintain the temperature in babies who are born at less than 32 weeks of gestation. For them, we don't wipe their body, but we place them in a food grade polythene bag, but we wipe the head of the baby and put a warm hat on, thus preventing the heat loss.
But let's assume after keeping the head in the neutral position, with your assessment of the CTBH, the baby did not recover. Now, after keeping the head in the neutral position, I'll be reassessing CTBH. The baby hasn't recovered. Baby is not breathing. Irrespective of the heart rate, you are going to commence inflation breaths to this baby. So you need elbow bag or the neopuff. I'll show you how to fix the neopuff later. And you will need the correct size mask for this purpose. Let's see how we are going to choose the correct size mask for this baby. The correct size mask should ideally cover the mouth and the nose like this, but should not go beyond the eyes or beyond the chin, like in this mask. This is too big for the baby. This is a smaller size. You can see, obviously, it is not sufficient to cover the nose and the mouth of the baby. So you're going to hold the mask from here. That's the C method. We are going to quickly fix it to the elbow. And you can see I'm using my thumb and the first finger, index finger, and I'm applying firm pressure on the baby's face to avoid leaking of air. And now I'm going to deliver the inflation breaths. 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. Make sure you are not applying pressure over the soft tissues of the baby's chin or the neck like this. So be very careful. Just to use your index finger and the thumb to apply pressure. If you want, the middle finger could be kept at the angle of the mandible. This is the E technique. But always you should avoid keeping your fingers over here. I'm going to again repeat inflation breath so that you can see the chest expansion that we are expecting while we are providing appropriate inflation breaths. Observe the chest now. 1, 2, 3, release. 2, 2, 3, release. 3, 2, 3, release. 4, 2, 3, release. 5, 2, 3, release. I hope you could appreciate the nice chest expansion. If you are providing the inflation breaths appropriately and there is no obstruction in the airway, we should be able to see a chest expansion like that. Again, I'm going to show you how to squeeze the elbow back. I'm going very slow. One, two, three, release. I wouldn't go like one, two, three. I will be very slow to provide sustained pressure for the baby. One, two, three, release. Two, three, release. So likewise, inflation rates should be provided in a very controlled manner using sustained pressure. After delivery of inflation rates, you have to ask two questions. First question is, did I achieve chest expansion? Second question is, what happened with the CTBH parameters? So if you had not achieved the chest expansion, the likely possibility is either you haven't given the inflation rates appropriately or there is an airway obstruction. So there are a lot of airway maneuvers that you can utilize in this situation to overcome this airway collapse or block. We will discuss about that later. However, even though you did not see a chest expansion, if a previously bradycardic or a baby who was in an asystole, if there is a good heart rate now, then you can actually assume that you have provided the inflation rates appropriately. That is the only exception. So if you don't see either a chest expansion or an improvement in the heart rate, you will have to go ahead with secondary airway maneuvers and to continue with the inflation rates before you proceed to the rest of the steps in the NLS algorithm. Let's go through the airway maneuvers we can practice if we fail to achieve appropriate chest expansion with our first set of inflation breaths. We are going to learn now how to provide jaw thrust. So we can do this as a double-handed jaw thrust if we have enough support. So this is how we are going to do it. Keep the head in the neutral position and then stabilize the baby's head while keeping the thumbs over the maxilla and then the third finger just behind the angle of the mandible. While maintaining this position, you have to push the jaw towards the ceiling. So this is your double-handed jaw thrust. With that, you need to ask the help from your colleague to place the mask in the face. And now your colleague will provide inflation breaths. One, two, three, release. Two, two, three, release. Three, two, three, release. Four, two, three, release. Five, two, three, release. If you could not achieve chest expansion with double-handed jaw thrust, you will have to directly visualize the airway inlet. For this, you will have to use a laryngoscope and then directly observe the airway. If you see any obstruction, like a blood clot, meconium, mucus plug, then you can use the suction catheter and suction it out. And then you will have to reattempt providing inflation breaths using your unguent mask. This could further be facilitated by inserting an oropharyngeal airway. I will show you how to choose the correct size and also how to insert the oropharyngeal airway later. One important thing to highlight at this point is never, ever you should be suctioning a newborn blindly without a proper indication. This is because if you suction blindly, this can stimulate the vagus nerve, which is running behind the pharynx, and this can lead to apnea and bradycardia in newborns. So blind suctioning should be avoided during resuscitation. Only indication for suctioning would be if you fail to achieve chest expansion, plus you see some obstruction in the airway. And you are going to always do it under direct visualization. So even after direct visualization, suctioning if necessary, if you can't achieve appropriate chest expansion, then you are left with intubation, which will be the final step in overcoming a potential obstruction in the airway. This is how you are going to insert the oral airway into a baby. So you have to use either a laryngoscope or a tongue depressor for this purpose. So you are going to visualize the airway and you are going to just insert the oral airway as it is. Unlike in adults, you don't have to turn it inside the mouth. So this is how you place the oral airway for a newborn baby. So after inserting the oropharyngeal airway, you can place your mask on top of this and continue with either inflation breaths or ventilation breaths. Let's assume you have delivered the 5 inflation breaths efficiently and you saw the nice chest expansion. So now we are going to reassess the CT BH. So here you can get 2 scenarios. First scenario is where the baby has completely recovered. This baby does not need any intervention. But let's say the baby has not recovered. The baby is not breathing. So what do you do in this situation? Irrespective of the heart rate, the second step in the NLS algorithm is to provide ventilation breaths. We are trying here to oxygenate the baby, hoping that the heart will start working. That's the primary aim. So now this is connected to the oxygen and get help. Ask someone to connect the baby into the pulse oximeter so that you can continuously monitor the saturation as well as the heart rate of the baby. And then we are going to provide ventilation breaths. We provide 15 ventilation breaths. So again, the same technique, head in the neutral position, C technique, appropriate seal, squeeze 1, squeeze 2, squeeze 3, squeeze 4, squeeze 5, squeeze 6, squeeze 7, squeeze 8, squeeze 9, squeeze 10, squeeze 11, squeeze 12, squeeze 13, squeeze 14, squeeze 15. I think you could appreciate the chest expansion in this situation also. After delivery of 15 ventilation breaths, reassess CTBH. You can get 3 scenarios here. First situation where the baby has completely recovered. We don't have to continue with the rest of the algorithm. Second situation is where now you have a nice heart rate, but the baby is not breathing. In this case, you will have to continue with the ventilation breaths until the baby recovers while continuously reassessing. Third situation is where the heart hasn't recovered. At the same time, the breathing has also not recovered. In this situation, we are going to now commence providing chest compressions for the baby while continuing with the ventilation breaths. You have to make sure that you have obtained senior support at this point. And remember, providing breaths and the chest compressions should be done in a synchronized manner. The ratio is 3:1. For 3 chest compressions, you are going to provide 1 breath. So let's see how we are going to provide chest compressions for a baby. There are 2 methods in providing chest compressions. The first and the better way is to totally encircle the patient's chest with your two hands and you go for a point just under an imaginary line drawn in between connecting the two nipples of the newborn. And you go just below that line and continue the chest compressions at a rate of at least 100 compressions per minute. At the same time, make sure you are compressing at least one third of this anterior posterior diameter. So we go like this: one, two, three, one, two. At the same time, you can use two fingers, which will be held like this. Again, the same anatomical side, and we go like one, two, three, four, five, six. But remember, I told you while giving the chest compressions, we have to always synchronize it with ventilation breaths. So let's see how we are going to do it together. One, two, three, squeeze one. One, two, three, squeeze two. One, two, three, squeeze three. One, two, three, squeeze four. One, two, three, squeeze five. Likewise, you are going to continue in the way of 15 ventilation breaths, and with that 3 to 1 ratio, you are going to continue the ventilation breaths along with the chest compressions. So after providing chest compressions, you are going to again reassess CTBH. There might be three scenarios. The first scenario is where the baby has completely recovered, so there is no further need to continue with the resuscitation. Second scenario is where the heart has now recovered and you see a nice heart rate. However, baby is not breathing. In this situation, you have to continue with the ventilation breaths. The third situation is where neither the heart rate nor the breathing has recovered. Now you have to go to the next step where you will be using medicines to support the heart. So in this scenario, we are going to quickly insert a UVC and then give adrenaline, zero point 0.2 milliliters per kg via this UVC for the baby during resuscitation. So every 3 to 5 minutes, you can continue with adrenaline injections. Make sure adrenaline is always followed by a saline flush to ensure that it is reaching the central circulation effectively. After successful resuscitation, perform the final assessment of the baby. Check the temperature, check the saturation of the baby, look for features of respiratory distress, check the blood sugar, and finally, document all what you have done in the notes very clearly and talk to the mother and explain what has been done already and what actions will be done in the future.